Okay, let's dive right into this. Welcome to The Explainer. Today we're unpacking one of the most deeply personal and honestly, fiercely debated concepts in human history. We're talking about bodily autonomy. We're going to look at exactly where law, human rights, and medical ethics collide with our physical bodies. Literally, the whole shebang, from the moment we can reproduce right up to the moment we die. So I want you to keep this one big question in the back of your mind today. Who ultimately has the right to make decisions about your body? I mean, it seems like it should have an incredibly obvious answer, right? You. But as you'll see, whether we're talking about reproductive rights or end-of-life care, it's this massive tug of war between personal freedom and societal frameworks. We're going to look at this totally impartially, just exploring the facts and the arguments exactly as they exist globally today.
All right, here is our roadmap for The Explainer. 1. Defining bodily autonomy. 2. The reproductive rights timeline. 3. Navigating end-of-life choices. 4. The human rights dilemma. 5. Global laws and statistics. And 6. The future of autonomy. Let's get into it.
Starting off with Section 1, Defining Bodily Autonomy.
So what do we actually mean by bodily integrity? Well, fundamentally, it's the right to self-determination over your own physical body, completely free from external coercion, no one forcing your hand. Now, the legal and ethical expertise surrounding this, it varies wildly from country to country, but the core attention is unified everywhere. It's the individual's right to choose versus what the state dictates. And this concept isn't just limited to one phase of life. It acts like a giant umbrella, spanning everything from a person's reproductive health to their end-of-life care.
Moving to the beginning of that spectrum with Section 2, the reproductive rights timeline.
Let's move to the timeline here and see how this builds. Starting back in 1960, the FDA approved the first oral contraceptive in the United States. And wow, this was a massive transformation. It allowed women to control their reproductive cycles and ushered in a huge shift in society and the economy. Then in 1969, the UN Population Fund was created. But as we know, progress is rarely a straight line, right? In 1984, the U.S. instituted the Global Gag Rule, which prevented U.S. aid to international organizations whose work involves abortion. Fast forward to 2012, and we see the UN passing its first-ever resolution calling for a worldwide ban on female genital mutilation. And then, jumping to 2022, the U.S. Supreme Court overturned the 50-year-old Roe v. Wade decision, putting abortion rights right back up for intense global debate.
Now, stepping back just a bit, the mid-1990s marked a really vital shift in how we even talk about this. At the 1995 UN World Conference on Women in Beijing, Hillary Clinton delivered a famously powerful quote, "Human rights are women's rights, and women's rights are human rights." This firmly linked women's bodily autonomy to universal human rights. Actually, during these global conferences, violence against women was finally recognized not just as some private domestic issue, but as a severe international human rights violation. This was an absolutely crucial step in establishing frameworks to protect bodily integrity.
And when we look at the modern landscape, you can see the debate over bodily autonomy is very much an active, ongoing, real-world issue. Recently, we've seen some significant global pushbacks against reproductive rights. For example, in Poland, massive protests erupted between 2018 and 2022 over a near-total ban on abortion. We already touched on the 2022 overturning of Roe v. Wade in the U.S., and then in 2023, the Taliban in Afghanistan literally ceased the sale of contraceptives. They used the threat of violence against pharmacies and labeled birth control a Western conspiracy designed to control the Muslim population. So it just goes to show you how heavily intertwined state power and personal bodily autonomy remain today.
That brings us to Section 3, Navigating End-of-Life Choices.
So if reproductive rights govern the beginning of life, how does autonomy apply at the very end? Let's talk about euthanasia. The word literally translates from the ancient Greek words eu meaning good and thanatos meaning death. In ancient Greece, it actually symbolized a beautiful death or a rational choice to just avoid terminal suffering. But that perspective shifted dramatically during the Middle Ages and Renaissance, where Christian doctrine largely condemned the practice. Fast forward to the 20th century and we see incredible medical advances prolonging life, but also horrifying historical abuses, like Nazi Germany's euthanasia program, which murdered individuals with disabilities under this totally false pretext of mercy killing. That dark, dark history absolutely underlines why the modern debate requires such strict guidelines today.
To really understand those modern guidelines, we have to carefully parse out the distinct categories of end-of-life assistance, because, trust me, they represent very different legal and ethical boundaries. First up is voluntary euthanasia. This is where a fully competent person gives explicit, informed consent. Next is non-voluntary. Here, the patient is severely incapacitated, and decisions have to be made by proxies, which, as you can imagine, raises some incredibly complex dilemmas. Then there is involuntary euthanasia. This is ending a life against someone's explicit wishes, and there is no debate here. This is universally considered illegal and ethical everywhere. Finally, there's assisted suicide. This one is distinct because the patient is provided the means, like a lethal medication, but they must independently perform the final act themselves, really emphasizing personal choice.
Let's explore the arguments in Section 4, the human rights dilemma.
The core debate here balances two massive philosophical pillars. On the one side, proponents argue from a human rights perspective of autonomy and self-determination. They argue that competent individuals should have the total freedom to prevent unnecessary, agonizing suffering when terminal disease is just unavoidable. For them, a dignified death is a fundamental right. But on the flip side, opponents argue fiercely for the sanctity of life. This includes religious views of divine prohibition, sure, but also strong secular concerns about protecting vulnerable populations from coercion. It also challenges the Hippocratic Oath, a doctor's fundamental duty to do no harm. Opponents argue that legalizing euthanasia could devalue the lives of the elderly or disabled, sending a really dangerous message to society.
Moving on to Section 5, global laws and statistics. So how does societies actually legislate this dilemma? Now, what's really interesting about this slide is just how incredibly varied global strategies are. It's not one size fits all. In Switzerland, they don't explicitly legalize euthanasia, but they do carefully regulate assisted suicide. The key requirement? The patient must be mentally competent and consenting. Meanwhile, over in the United States, Oregon passed the Death with Dignity Act in 1997. This allows terminally ill residents to request lethal medication, provided multiple doctors confirmed they literally have less than 6 months to live. And then look at India. Following a landmark case, active euthanasia remains strictly illegal there. They only allow passive euthanasia, which means withdrawing life support, and only for patients in persistent vegetative states.
When we look at places where the individual right to die principle is most prominent, like Canada, we see some truly staggering statistics that complicate the whole debate. In 2021 alone, over 10,000 Canadians died from euthanasia. That was a 32.4% surge from the previous year. But what is truly sobering are the factors the patients themselves cited. While terminal illness is the baseline, 36% of these patients cited feeling like a burden on family, friends, or caregivers as a factor in their decision. Another 17% cited isolation or loneliness. These data points highlight the exact fear opponents have, that societal failures in providing care and support might actually pressure vulnerable individuals into ending their lives.
And this brilliantly illustrates the real-world impact of how laws are designed. If you notice the bottom of the graph, the frequency of euthanasia and assisted suicide remains pretty minimal in places where strict terminal phase rules apply, like in Oregon. But look at the steep rising curves for the Netherlands, Belgium, and Canada. In jurisdictions that prioritize the broader individual right to die and use criteria like unbearable suffering, the growth rates for these procedures are significantly faster. It really shows how policy shapes practice.
Bringing it all together now in Section 6, the future of autonomy.
You know, whether we're dealing with reproductive choices at the very beginning of life or palliative care at the end of life, the idea of pure individual liberty doesn't always paint the full picture. The reality is something called relational autonomy. It's the idea that our choices are always made within the context of our relationships, our families, and frankly, the quality of care available to us. A true right to health requires world-class palliative and supportive care, so that choices are driven by true autonomy and not by a lack of options or feelings of total isolation.
We'll wrap up this explainer with a really provocative thought from author Joe Nesbo. What is worse, taking the life of a person who wants to live, or taking death from a person who wants to die? So the crucial point is that bodily autonomy is not a settled debate. It's a fragile, constantly evolving spectrum of rights that challenges the ultimate boundaries of personal freedom against the values of society. Thank you so much for joining me for this explainer, and I really encourage you to keep questioning where exactly those boundaries should lie.